Welcome to our in-depth exploration of cardiac function. In this last section of the series about cardiac function, we'll cover the final part of Chapter 17 of the Pathophysiology book by Jacquelyn Banasik and Lee Ellen Copstead. Here's the index of topics: electrocardiography, determinants of cardiac output, endocrine function of the heart, and final topic of this series of Chapter 17, tests of cardiac function. Let's dive right in. Electrocardiography, ECG or EKG, is a fundamental non-invasive diagnostic tool test used to evaluate the electrical activity of the heart, detected by electrodes placed on the skin that captures voltage changes as the heart muscle depolarizes and repolarizes. It provides critical information about the heart's rhythm, electrical conduction, and overall cardiac function. This is well illustrated in Figure 17.22 of the chapter. Now let's move on to some basics of ECG, starting with the recognition of waveforms. There are three major waves and complexes that we have to identify. P wave represents atrial depolarization, indicating the electrical activity associated with atrial contraction. QRS complex reflects ventricular depolarization, the process of electrical activation of the ventricles leading to their contraction. It is typically a sharp, tall spike on the ECG. T wave indicates ventricular repolarization, the recovery phase of the ventricles after contraction, preparing them for the next cycle. U wave, sometimes seen after the T wave, particularly in those with slow heart rates. Prominent U waves can also be a sign of a low potassium level. Intervals and segments. Key intervals and segments include PR interval, time from the onset of atrial depolarization to the onset of ventricular depolarization. ST segment, time between the end of ventricular depolarization and the start of repolarization. QT interval, duration of ventricular depolarization-repolarization. Later, it would be explained a bit more about ECG. Determinants of cardiac output. Cardiac output is a measure of the amount of blood pumped out of the heart each minute. Normal resting cardiac output is approximately 5 to 6 liters per minute, but it varies with body size and age. Cardiac output is often indexed to body surface area in an attempt to adjust for these differences. This can be represented by the next formula: cardiac index equals cardiac output / body surface area. Consider that a normal cardiac index ranges from 2.8 to 3.3 liters per minute per square meter. Cardiac output is a product of heart rate and stroke volume, commonly represented as the next formula: cardiac output CO equals heart rate HR stroke volume SV. Based on this formula, an increase in heart rate and/or an increase in stroke volume will result in a greater cardiac output. Conversely, a low heart rate and/or a decreased stroke volume will cause cardiac output to fall. To a certain extent, a change in one factor can be compensated for by a change in the other, thus maintaining cardiac output at a constant level. For example, it is common for an individual with limited volume attributable to cardiac disease to have a high resting heart rate. Any physiologic, pharmacologic, or pathologic process that alters heart rate or stroke volume may affect cardiac output and therefore tissue perfusion. Let's look at the determinants of heart rate. Heart rate is primarily influenced by the autonomic nervous system. Release of norepinephrine, NE, by sympathetic nerve endings results in an increased heart rate. A similar effect results from circulating norepinephrine and epinephrine released from the adrenal gland during sympathetic stimulation. So, basically, detection of inadequate blood pressure, a lack of oxygen, or a buildup of metabolic end products results in activation of the sympathetic nervous system. Specialized sensory nerve endings called baroreceptors are located in the aortic arch and carotid arteries. They respond to changes in blood pressure and transmit this information to the central nervous system, CNS, by way of cranial nerves 9 and 10. A decline in blood pressure causes parasympathetic system inhibition and cardiac sympathetic nerve activation, resulting in a rise in heart rate. Conversely, a rise in blood pressure causes the heart rate to fall because of parasympathetic activation and sympathetic inhibition. Under normal resting conditions, the heart rate is under parasympathetic influence, with a usual rate of approximately 70 beats per minute. In addition to baroreceptors, other sensory fibers that detect pressure are located in the cardiac chambers. These sensory receptors respond to changes in intrachamber pressure, which reflect the volume of blood in the chamber. Atrial or ventricular overdistension suppresses parasympathetic influence and increases heart rate, Bainbridge reflex. Heart rate may also be influenced by higher central nervous system activities that do not involve reflex pathways, such as anxiety, fear, stress, excitement, trauma, and fever, all of which may activate the sympathetic system, for example. A variety of drugs can mimic or block the effects of both sympathetic and parasympathetic systems, and therefore influence heart rate. In general, an increase in heart rate results in an increase in cardiac output. However, at very high heart rates, cardiac output may actually fall. Now let's move on to the determinants of stroke volume. We've been talking about stroke volume, but let's give it a definition. Stroke volume refers to the amount of blood ejected from the ventricle with each contraction. In other words, it is the volume of blood pumped from the left ventricle with each contraction. It is influenced by three major factors: preload, afterload, and contractility. Let's analyze each one. 1. Preload, the initial stretching of the cardiac myocytes prior to contraction related to the end diastolic volume, EDV. 2. Afterload, the resistance the heart must overcome to eject blood, primarily determined by systemic vascular resistance, SVR, and pulmonary vascular resistance, PVR. 3. Contractility, the intrinsic ability of the cardiac myocytes to generate force, independent of preload and afterload. Positive inotropic agents increase contractility, while negative inotropic agents decrease it. Each of these factors is in turn influenced by many other physiologic, pharmacologic, and sometimes pathologic variables. Cardiac workload. Cardiac workload refers to the amount of effort the heart must exert to pump blood throughout the body. The four determinants of cardiac output described in the previous section, heart rate, preload, contractility, and afterload, are also the major determinants of cardiac energy requirements. An increase in any of these four factors will increase ATP requirements and therefore cardiac cell oxygen requirements. The heart has endocrine properties, secreting various hormones that play roles in cardiovascular regulation. Atrial natriuretic peptide, ANP, released by the atria in response to increased blood volume and pressure. ANP promotes natriuresis, excretion of sodium in urine, vasodilation, and a decrease in blood volume and pressure. B-type natriuretic peptide, BNP, secreted by the ventricles in response to the stretching of the myocardial wall. BNP helps to reduce preload and afterload, acting similarly to ANP. Endothelin, a potent vasoconstrictor produced by endothelial cells, playing a role in regulating vascular tone and blood pressure. Now let's move on to the last topic of the chapter, tests of cardiac function. In addition to patient history, laboratory results, and physical assessment, a number of diagnostic tests may be employed to evaluate cardiac function. Some of these studies are briefly described in this section. Electrocardiography. The ECG graphically indicates electrical currents generated by cardiac cells. The current is registered by skin electrodes placed in particular positions on the body. The standard ECG has 12 different leads that are obtained through 10 skin electrodes, 3 standard bipolar limb leads, 3 augmented unipolar limb leads, and 6 unipolar chest leads. ECG leads and their placement. Types of ECG leads. As mentioned before, there are bipolar leads, which represent a difference in electrical potential between 2 electrodes, one positive and one negative. Augmented unipolar limb leads, which represent a difference in potential between one electrode and the average of the other 2 limb electrodes. Unipolar chest leads, which represent a difference in potential between the chest electrode and a location at the center of the heart. Each lead provides a different ECG because of its particular view of current flow through the heart. Additionally, we can also categorize ECG leads in a more general way into limb leads and precordial chest leads. Standard limb leads, also called bipolar leads. They are placed on the limbs and measure the electrical activity in the frontal plane of the body. These leads are lead 1, which measures the electrical potential between the right arm, negative, and the left arm, positive. It provides a lateral view of the heart. Lead 2 measures the potential between the right arm, negative, and the left leg, positive. This lead is often used for continuous monitoring as it gives a clear view of the P wave reflecting atrial activity. Lead 3 measures the potential between the left arm, negative, and the left leg, positive. Like lead 1, it provides a lateral view of the heart, but from a different angle. On the other hand, we have augmented limb leads, also known as unipolar leads. The augmented limb leads are also recorded from the limbs, but are unipolar, meaning they measure the electrical activity at one electrode relative to a composite reference of the other two. These leads are AVR, due to augmented vector right. It measures the electrical activity from the heart toward the right arm. It typically shows a negative deflection because the heart's main electrical vector moves away from the right arm. AVL, given to augmented vector left, measures the electrical activity from the heart toward the left arm. This lead often shows a positive deflection as the heart's electrical activity moves toward the left side. AVF, because of augmented vector foot, and it measures the electrical activity from the heart toward the left leg. It typically shows a positive deflection because the electrical activity moves downward toward the leg. Now, let's dive into the precordial chest leads. The precordial leads are placed on the chest and provide a transverse, horizontal view of the heart's electrical activity. These leads are unipolar and give a detailed view of the heart's anterior and posterior walls. Lead V1, placed in the fourth intercostal space to the right of the sternum. It provides a view of the right ventricle. Lead V2, placed in the fourth intercostal space to the left of the sternum. It also views the right ventricle. Placed midway between V2 and V4, this lead views the anterior part of the heart. Lead V4, placed in the fifth intercostal space at the midclavicular line. It provides a view of the anterior part of the heart, particularly the apex. Lead V5, placed in the fifth intercostal space at the anterior axillary line. It gives a lateral view of the heart. Lead V6, placed in the fifth intercostal space at the mid-axillary line. It provides a lateral view of the heart. What is the purpose and importance of lead placement? Each lead provides a different perspective on the heart's electrical activity, which is essential for diagnosing various cardiac conditions. Proper placement of leads ensures accurate and reliable ECG readings. Here's why each lead is important. Leads A, 2, 3. These leads help in assessing the overall direction of the heart's electrical activity and are particularly useful in detecting atrial rhythms and axis deviations. Leads AVR, AVL, AVF. These leads provide additional perspectives on the frontal plane, aiding in the diagnosis of conditions like myocardial infarction and chamber enlargement. Leads V1, V6. These leads give a detailed view of the heart's anterior, lateral, and posterior walls, essential for identifying specific areas of ischemia, infarction, and hypertrophy. If you would like me to explain ECG in more detail, be more specific, and explain how to interpret it, leave a comment. I would be delighted to prepare material for it. Read you in the comments. Next tests: magnetic resonance imaging and computed tomography. Magnetic resonance imaging, MRI, and computed tomography, CT, are useful for imaging cardiac structures. Myocardial thickening, pericardial sac disease, valvular structures, and congenital malformations may be visualized by MRI. Contrast-enhanced imaging identifies acute and chronic myocardial infarcts with high specificity and sensitivity. MRI and CT are used to detect coronary plaque burden and assess vulnerable plaque morphology in the arterial walls. Excessive plaque burden and unstable plaques are correlated with a greater degree of coronary atherosclerosis and may be used to predict coronary artery disease risk or progression. Echocardiography. Echocardiography uses reflected sound waves, ultrasound, to provide an image of cardiac structure and motion within the chest. The cardiac echo is obtained by placing a blunt probe on the chest surface, which transmits and receives high-frequency sound waves. Sound waves traveling through chest and heart structures are reflected back to the receiving probe. The time between sound wave emission and detection of reflected waves is used to calculate distances between the probe and reflecting tissue. The sound waves are not heard or felt by the subject and have no known detrimental effects on tissues. The probe is moved across the chest to assess cardiac structures of interest, and recordings are videotaped for later viewing. Echocardiograms are particularly useful for diagnosis of heart enlargement, valvular disorders, collections of fluid in the pericardial space, cardiac tumors, and abnormalities in left ventricular motion. Estimations of ejection fraction and assessments of ventricular systolic and diastolic function can be made non-invasively by echocardiogram. An echocardiogram is shown in Fig. 17.35. Nuclear cardiography. Radioactive substances injected into the bloodstream can be used to trace the patterns of blood flow in the heart. Radiation exposure is minimal because very small amounts of radioactive substances are used. Radioactive tracers can be linked to substances that accumulate in normal myocardial cells while the tracer is delivered by coronary blood flow. Areas with impaired perfusion will absorb less radioactivity and appear as cold spots on the scan. Scanning usually is done using single photon emission computed tomography, SPECT, which images numerous slices through the heart, or by planar imaging, which gives an overall picture in one plane only. Thallium-201 and technetium-99 labeled compounds are used to assess the adequacy of blood flow to cardiac tissues. After injection of the radioactive compound, the heart is scanned to visualize the amount of radioactivity absorbed by cardiac tissues. Healthy cardiac tissues that receive adequate blood supply actively accumulate these isotopes. Areas of inadequate blood flow or infarcted tissue do not accumulate isotopes and appear as cold spots on the scan. Computer imaging is used to analyze blood flow through the chambers of the heart over many cardiac cycles. The dynamics of ventricular motion, such as hypercontractility or hypocontractility, may be visualized. SPECT scanning allows simultaneous evaluation of perfusion and left ventricular function. Positron emission tomography scans may also be used to evaluate cardiac perfusion and metabolism. Radio tracers can be incorporated into substances normally used in cellular metabolic processes, such as glucose. Metabolic activity in different areas of the heart can then be tracked over time under different conditions. Cardiac catheterization, coronary angiography. Cardiac catheterization, coronary angiography may be used to determine important structural and hemodynamic characteristics because it affords direct measurement of pressures within cardiac chambers, visualization of chamber size, shape, and movement, sampling for blood oxygen content in various heart regions, measurement of cardiac output and ejection fraction, and visualization and management of coronary artery obstructions. Cardiac catheterization angiography is associated with several serious risks, including bleeding, dysrhythmias, heart perforation, and coronary ischemia. Catheterization is frequently used for interventions to rapidly improve coronary blood supply and to evaluate suspected or confirmed coronary artery disease, valvular dysfunction, congenital defects, left ventricular dysfunction, and coronary bypass graft patency. Assessment of the left side of the heart, including the coronary arteries, is achieved by passing a catheter through a femoral or brachial artery into the aorta. The catheter is then manipulated into the left ventricle or left atrium to assess chamber pressures, and a ventriculogram is obtained. Contrast dye injected into the ventricular chamber is monitored fluoroscopically to assess ventricular function. The catheter is usually pulled back into the aorta and then advanced into one or more of the coronary arteries. The patency of the coronary arteries can be visualized by injecting contrast dye into them and monitoring by fluoroscopy, such as the Fig 7.36 shows. When contrast dye is in the coronary artery, a period of cardiac ischemia is produced during which the patient may experience angina, dysrhythmias, and coronary spasms. Coronary catheterization may also be done to insert a probe for obtaining intracoronary ultrasounds. Ultrasounds are useful for assessing plaque morphologic characteristics. Right-sided heart catheterization is done to evaluate right-sided heart structures. The catheter is introduced into a vein, usually femoral, and then threaded through the inferior vena cava and into the heart. Pressures and blood samples are obtained as the catheter is advanced into the right atrium, ventricle, and pulmonary artery. Right heart catheterization is useful in assessing tricuspid and pulmonary valve disorders, pulmonary hypertension, septal defects, and right ventricular function. Coronary angiography is commonly followed by interventions to treat detected abnormalities. The coronary catheter can be used to direct thrombolytic agents to the site of coronary thrombosis and rapidly restore blood flow to ischemic areas. Laser therapy, coronary balloon angioplasty, and stent placement can also be performed during coronary angiography. These methods clear the coronary obstruction through thermal and mechanical means. The success of these approaches to management of coronary obstruction depends largely on how soon after an ischemic event they are performed. Thank you for joining us in this detailed exploration of cardiac function. This video is part 3, last, of a series of videos already in the channel about the whole basis of cardiac function related to Chapter 17 of the book Pathophysiology by Jacquelyn Banasik and Lee Ellen Copstead. Stay tuned for more informative content not only in cardiology but also in other branches of medicine. If you found this content useful, please like the video, share it with others, and subscribe to our channel. Don't forget to activate the notification bell to stay updated on all our latest content.